We'll today discuss about the cranial nerves. I'm not going into the full details of the cranial nerve examination. I have highlighted a few points which I feel are important for examination purposes. We'll start with the first cranial nerve. We can see a beautiful bunch of flowers here. So the beauty of flowers or the enjoyment of flowers increases with the smell of the flowers. So we'll go on to the first cranial nerve. So what to do and what you find when you examine the first cranial nerve. So you can use simple bedside objects like a piece of fruit and orange. I have said orange because I love oranges. You can use soap or whatever is available offhand at the site. If you have to formally select substances, then you can use peppermint oil or camphor or rose water or coffee powder. The idea is to check each nostril separately. You should ask the patient to close his eyes and check each nostril separately. You should use different substances for each of the nostrils. So is ammonia included? So most of the books say no because it irritates the non-olfactory receptor. So it's not exactly the smell you are checking, it is the irritation or the stimulation. So what do you find? Patient able to identify odors appropriately, that is normal. Patient is unable to recognize scents offered but recognizes ammonia, that is anosmia. He is not able to identify the odors but ammonia irritates the other receptors, that is anosmia, which can be unilateral. If the patient is not able to appreciate the smell nor the ammonia, it is a hysterical cause, it's not entirely organic. What are the common causes of anosmia? Bilateral, it's due to a common cold. More relevantly, it's due to trauma, and relative loss of odor can occur with aging and Parkinsonism. Unilateral anosmia is more significant by bilateral anosmia because it indicates either a meningioma or a glioma. So in examination of the eyes, you should do the general examination of the eyes, the pupils, the acuity of the vision, the fields, and the fundi. So a brief word about the pupillary examination. So pupillary light reaction, as we all know, the afferent is the optic nerve, the efferent is the parasympathetic component of the third nerve on both the sides. For the accommodation reaction, the afferent arises in the frontal lobes. That's very important. For accommodation reaction, the afferent arises in the frontal lobes. For efferent is the same as the pupillary light reaction. That's the parasympathetic component of the third nerve. So acuity can be affected due to various causes. Commonly in the elderly people, it's due to the cataract, optical problems, or either the refractory errors, long or short-sightedness, are usually amenable to pinhole correction. Retinal or retroorbital causes of loss of acuity cannot be corrected by glasses. So when you have pupils which are large, what are the interpretations? So large pupils which reacts to light normally, it indicates anisocoria, variation in the size of the pupils. Large pupils doesn't react to light but normal accommodation. In fact, on doing the swinging flashlight test, the pupil dilates. It's the typical Marcus gun pupil, which indicates a relative afferent pupillary defect. So when a large pupil, there is a slow accommodation response. There's another entity called Holmes Addis pupil. A large pupil where there is no accommodation, but there is uh, ptosis, then is probably a third nerve palsy. When there is no ptosis, but the pupils are large, you should suspect use of mydriatic drugs. So we testing the visual field defects. Uh, Monoocular field defects. So there is a reference point, the optic chiasm. So if the lesions are anterior to the optic chiasm, then the defects are monoocular field defects. At the level of the optic chiasm, it's the bitemporal field defects. Behind the optic chiasm, it's the homonymous field defects. So you have what is known as the congruous homonymous field defect, where the lesion is behind the lateral geniculate bodies. Congruous is exactly the same the field defect which occurs in both eyes, that is congruous. So this is a graphic representation of how you check the visual fields. Here the peripheral visual fields are being checked. You use either your index finger or a white pinhead in what is commonly known as the confrontation test. So the line what you see is the reference point. Uh, uh, it's checked one eye at a time. The patient and the examiner both close one of their eyes, and the right eye of the patient is checked by left eye of the patient. Patient is asked to focus on the eye of the examiner. So this is the reference point, and you check the visual field for about 30 centimeters around this uh, reference line. So in all directions. So if this is north, the bottom is south, this is northwest, this is northeast, this becomes southeast, and this becomes southwest. So you check in all the directions. This is checking of the uh, peripheral visual fields, usually with a white pinhead or your index finger. It is used for screening purposes. So there is an entity called as visual attention, where you ask the patient to look with both eyes at your eyes. Put your hands on both sides approximately 50 centimeters apart and approximately 30 centimeters above eye level. Extend your index finger. Your fingers will be in the upper temporal fields on both the sides. So ask the patient to indicate which index finger you move, right, left, or both. Repeat with hands 30 centimeters below the eye level. Ignoring one side when both fingers are moved is visual inattention. So coming back to the visual fields, central vision is color vision and peripheral vision is monochrome, white or black. So white pin for screening and for peripheral visual field defects. Red-headed pins are used to assess defects of central vision and are more sensitive for other field defects. So this is the visual pathway. As you can see, this is the retina, the optic nerve, the optic chiasm, the optic tract. This is the geniculate body. These are the radiations through the temporal and the parietal lobe, and this is the occipital cortex. So lesion at various levels produces different types of visual field defects. So whenever there is homonymous hemianopia, the macula needs to be tested. So what happens is when you are looking for central visual field defects, or while checking the macula, you should imagine a horizontal plane, vertical plane in between the eyes of the examiner and that of the patient. So you check the uh, visual field in a vertical plane which is approximately midline between the examiner and the patient. So you bring the pin horizontally from the side with a defect towards the point of fixation. If the pin is seen before it gets to the midline, there is macular sparing. If the pin is seen only after it crosses the midline, then there is macular involvement. So central field defects, you have scotomas and the blind spot. They are usually detected with the red-headed pin. So when the field defect is limited to one eye, it indicates ocular, retinal, or optic nerve pathology. When the field is constricted, it is chronic papilledema and glaucoma. Tubular vision indicates hysteria. When there are central scotomas, it is usually due to optic neuritis. In multiple sclerosis, toxic optic neuropathy, ischemic optic neuropathy, retinal hemorrhages are infarcts. Altitudinal defects suggest a vascular cause. So, what are these altitudinal defects? They are either upper quadrant or lower quadrant defects, but they cross the vertical line, which is a reference point. So, in hemianopias, it doesn't cross the vertical line in the center, whereas in altitudinal defects, it crosses the midline. So, what are the visual field defects affecting both the eyes? So, you have the classical bitemporal hemianopia, where the upper quadrant involvement is more than the lower quadrant involvement, commonly seen in pituitary adenomas. If the lower quadrant involvement is more than the upper quadrant involvement, it indicates superior chiasmal compression, which usually occurs in craniopharyngiomas. So in homonymous hemianopias, as we discussed, there are congruous and incongruous lesions. Incongruous lesions usually are of the optic tract, whereas congruous lesion is behind the lateral geniculate body. There is macular sparing in lesions of the optical cortex. So in homonymous quadrantopia, only a quadrant is involved. If the upper quadrant is involved, then you suspect a temporal lobe involvement, and the lower quadrant involvement indicates that of the parietal lobe. So it's very important to localize. So next, what you do when you have small pupils. So small pupils which reacts to light in an elderly person is usually senile miosis. With ptosis, anophthalmos, and anhidrosis, it's the classic Horner syndrome. It doesn't react to light, but accommodation is normal, and the pupils are irregular. It is the classical Argyll-Robertson pupil. When there is no accommodation in a small pupil, then you should suspect the use of myotic drugs. So this is again a summary of the pupillar involvement. So the Holmes-Addy pupil or the tonic pupil, it's a unilateral large pupil. The reactivity to light is sluggish. The reactivity to accommodation is normal. The site of lesion is the ciliary ganglion. Then you have the classical Argyll-Robertson pupil, where you have bilateral small irregular pupils. The reactivity to light is absent, whereas the accommodation reflex is present. AR, Argyll-Robertson pupil, accommodation reflex is present, and the lesion is in the midbrain. Then you have the Horner syndrome, where you have unilateral small pupil and ptosis. The reactivity to light is normal, accommodation is normal. The site of lesion is the sympathetic innervation of the eye. Then the Marcus Gunn pupil, where the appearance is normal, and reactivity to light, the consensual reaction is more than the direct response. In fact, when you shine the torch, the pupil may paradoxically dilate while doing the swinging flashlight reflex. The accommodation reflex is almost normal, and the site of lesion is in the optic nerve. So these are a few salient features in examination of the first and second cranial nerves. Thank you.